The next speaker is also going to carry on in the same vein. It'll be a virtual presentation. It's by Dr Rik Dawson, who happens to be in Melbourne today, but he's going to give his talk from there. In his PhD, he really focused on research into the effectiveness, cost-effectiveness and implementation of physiotherapy and telehealth interventions in reducing falls, improving mobility and enhancing quality of life across various settings. But today he's really going to focus on nursing homes, and that's the topic of his talk, if it's all lined up, hopefully. And it's preventing falls in nursing homes, and this time an Australian perspective. So welcome to Rik.
Thanks, Steve. I just want to make sure everyone can hear me.
It can, all is good.
Okay, and I'm going to progress my slides to make sure I can do that, but of course now my little button's not working. Let me just go down here. Okay, so thank you for the opportunity. I'm sorry I can't be there in person. Managing two workloads sometimes is a bit tricky, but I really appreciate the opportunity. Really what I wanted to talk to today is to talk about the impact that the Australian reform in aged care has had on the ability for us to deliver fall prevention programs in residential aged care. And then I want to talk a little bit about emerging programs that we are seeing on the floor, and then just a little bit of a plug for researchers like myself that are using telehealth and digital interventions to support falls prevention. So I know we all know the issues of falls in our residential aged care, but we have at least 50% of people in residential aged care falling. That's probably drifting up to about close to 2/3 each year. And we have a number of recurrent fallers that are really tricky to manage and to reduce future falls for these people. And I'm just presenting you a logic model framework for understanding the influences of fall prevention in aged care. And it shows how the system level components of inputs, processes, outputs and outcomes interact to shape effective fall prevention. So I'm going to explore a little bit around the new staffing level and skill mix that have been influenced by some reforms to determine the capacity to deliver prevention programs. Some of the processes like care standards and emerging guidelines and how they influence. Clearly, funding really influences the outputs of these programs, and what are the outcomes and how are we measuring that? So over the last couple of years, we've seen a dramatic improvement on care minutes. So we now have mandated care minutes and of what aged care facilities are expected to deliver from a care staff and a registered nurse. But unfortunately, care minutes didn't include allied health or lifestyle programs. So that takes and makes it very difficult to embed non-nursing approaches within these programs. And what we've seen since the introduction of care minutes, we've seen allied health drop from 11 minutes a day to 4 minutes per resident per day. And if we look at the Royal Commission, there's recommendations that allied health care minutes should sit above 20 minutes. So we're a long way to being able to have the staff resources to deliver multidisciplinary fall prevention programs. We now have the new aged care standards, and what's really good about these aged care standards, there is a lot of expectation about delivering evidence-based fall prevention programs, and these do influence what facilities are now providing. We've also seen the introduction of mandatory quality indicators, and as you can see, we do have a specific one on falls and major injuries. So each facility now needs to measure the percentage of care recipients who experience one or more falls and the percentage of care recipients who experience one or more falls resulting in major injury. So this has been really influential. But I think if you look at the care minutes, and soon we're going to talk about funding, we've actually seen that falls has stayed the same since the introduction of these quality indicators, when you see some of the other indicators that are very much nursing focused or care staff focused have actually started to drop. So having demonstrable indicators around falls is not enough. In July this year, we're going to have a new Aged Care Act. And what's really good about that has some really good principles about rights-based approach for how to care for the residents living in our nursing homes. We've got the new strengthened aged care quality standards that's going to encourage evidence-based practice, including falls prevention strategies. Where there's an encouragement to have multidisciplinary care planning, we're going to explore that in a little bit, and there's going to be enhanced provider accountability. So let's just have a quick look at what new standards are going to recommend. So there is a focus on maintenance or restoring independence and daily tasks. There's an expectation that no resident will be charged for any rehabilitation type assessments, and they encourage arranging health visits. But what they don't specifically call out is that the facilities do not have to fund intensive long-term rehabilitation services following a serious illness or an injury like a fall. So yes, there's going to be, they're expected to deliver maintenance therapy. What does that look like? They're expected to deliver restorative care therapy, but they don't have to deliver long-term. And we know with a lot of evidence around falls prevention, we need to maintain these service levels. There are some really great opportunities coming up in the supported home program in the community that has a real focus on funding for rehab and restorative care packages. So we're going to see starting from July 1, 20,000 12-week packages delivered, which is really positive. It's going to enable home care providers to have integrated care planning, multidisciplinary assessment and care. It's going to improve access to these people, focusing on measurable outcomes and goals. And it's going to give providers the flexibility to deliver the services that their clients need. And we know that in Australia, we're going to get the new Australian Fall Prevention Guidelines, which I think will go a long way to influence fall prevention programs. And just a real sneak peek about what's going to be one of the exercise recommendations. The research is saying that tailored supervised exercise delivered at moderate intensity should be provided for those willing and able to participate. But once we stop these programs, the effects of these exercise programs end. So if we want to reflect a little bit around some of the funding, just want to talk a little bit about the block funding, the Australian National Aged Care Classification, which basically people get a certain amount of funding in residential aged care to deliver deliver programs to support their needs, and it's going to be person-centred. But as you can see from previous slides, there's no specific funding for this ongoing approach. So we know that fall prevention for those 50 to 60% that fall each year and those 20% potentially that have repeat falls, they need intensive programs. And we don't have the structure at the moment to support that. We don't have the funding to support that. And we don't have the staff to really deliver those programs. I think there is a workforce out there from a multidisciplinary approach that really want to be involved in residential aged care to deliver really good work, but we haven't quite nutted out what needs to happen to support facilities to have the funds and the staff to provide these programs. So what is happening as of May 2025? I think you can look around at Australia and we can see really good fall risk assessment and review. You talk to managers of facilities, they really value allied health assessments. They really value their input into multidisciplinary care planning so that we can address falls. We're starting to see some new nutrition programs emerging based around some of the work like Dr. Giuliano from down at the University of Melbourne. We're starting to see some introduction of some really good exercise programs, a lot of it based around Dr. Jenny Hewitt's work on the Sunbeam program, but it is variable because we don't have the systems, funding and supports locked in for falls prevention. So from an aged care accreditation and the new Aged Care Act, you will see really good screening around falls risk. There will be care plans in all the documented systems that are pretty much all online now that demonstrate a comprehensive falls risk assessment that is really multidisciplinary in its approach. We're assessing their level of cognitive impairment, delirium and vision and medicines all affecting falls. We're seeing really good care planning around how we deliver these sort of programs. And we're getting some tailored fall prevention plans based around a lot of the research, exercise, environmental modifications, medication changes. There's increasingly really good communication happening between care teams, the person themselves, their families, with multidisciplinary approach. But basically, because the funding is blocked, it's really up to the providers to deliver these programs out of their block funding, and there's no specific funding for these programs. We're seeing really good post-fall management because facilities and staff, all of us who work in residential aged care, we don't want to see falls. We don't want to see the injuries from falls. So we're seeing really good post-fall management, really good immediate care. People are getting appropriate care. They're being transferred into acute care system when required. We're starting to see some really good linking programs back from acute care, getting residents back into their homes, because we know that best care is happening in their home, which is in residential aged care. So we're starting to see really good care programs. But as I mentioned before, the falls rate isn't coming down. I just want to reach out really quickly as a shout out to Sandra Giuliano's work in residential aged care. We're seeing some really good new research emerging through University of Canberra, where this is being embedded, led by Steve Isbell. And Sandra's work has been influential in understanding the importance of nutrition when it comes to maximising residents' levels of calcium and protein, because her research has shown it did reduce falls, but importantly reduces the rate of hip fractures. So we're starting to see kitchens and chefs and facility providers investigating the type of food. And we did know a few years ago, outside of the Royal Commission, one of the outcomes was a lot of media attention around food. And Maggie Beer has been a really great champion of good food in residential aged care. Good food that's nutritious, that is evidence-based, but is also really appealing. We've also seen the emergence of some really good outcomes from Jenny Hewitt's work with the Sunbeam program. So we're starting to see some group classes that based on her program, which is progressive resistance and high challenge balance programs, prescribed and upgraded generally by physiotherapists, and sticking to the program, which Jenny's program was saying that you need to do 2 one-hour sessions a week with ongoing maintenance up to groups of 10 residents. And the program was based around the Otago exercise program that has been well adapted and utilised within the university training. So everyone's very familiar with these programs. And it's also following sort of the strength and conditioning guidelines that have been around in the sporting fields, and we're getting replication of this within aged care. But we do know from a lot of the work, say from Kathy Sherrington's Cochrane Review and Community, and also the updated Cochrane Review that's coming out, led by Ian Cameron and his team, that it needs to be strength and balance. I also, speaking as an academic from the Institute of Musculoskeletal Health, but also as the National President for the Australian Physiotherapy Association. So at the APA, we love evidence-based research, and we especially love evidence-based research that has cost-effective analysis embedded in it. So Jenny Hewitt's work did look at that, and so able to understand the impact of these programs in residential aged care, these exercise programs, where we're almost getting a cost-benefit ratio of 2 to 1. So for every dollar invested, we're getting a benefit of $2 to the healthcare system. And it's really important that any researcher out there looking at doing any sort of research in aged care, we need that economic analysis embedded in programs so that we can sell this to reform and stakeholders in government and the like. So as you can see here, we've got that's me as part of my work doing a seated exercise program. So if you go, my mother-in-law lives in a nursing home. When we go to visit, we get up into the lift and we can see what exercise programs are being conducted. So you're starting to see some really good seated recreational exercise everywhere. And there's so much benefits to seated exercise, from a cardiovascular and an upper body and a lifestyle and cognitive stimulation. But generally speaking, they're run by a lifestyle team with or without resources like, say, some of my top-up videos, but they're seated. So from a fall prevention focus, we need to get people up and standing. Once we get these very frail people in standing, there's risk, and they need a high level of supervision to be able to deliver this in a group setting. So there's a lot more work to be done. So I just want to briefly touch on some of the telehealth exercise programs. This is just the top-up study that that formed the basis of my PhD. I had the opportunity last year to present to this forum the details, and the article is still under review with the leading Australian journal. Just a little bit of a summary. It was a 6-month trial. It was a model of care that focused on delivering telehealth physiotherapy using Zoom. We encouraged the residents to exercise for 2 hours a week, supported by exercise videos. It was based on the Otago program, and it was progressive and tailored to the individual, and we really wanted to get them on their feet as soon as we could, as safely as we could. But we did know in this model of care that having support, one-on-one support with these residents is really important, and building that in each week. So as you can see, I put 1 hour a week into this program for each resident. We were able to improve their mobility, reduce their risk of falling due to the size of the trial. Even though it looked like we were about to reduce their falls rate by 40%, we just statistically not significant, mainly due to the size of the trial. So there needs to be an opportunity to do a larger trial of telehealth. And it was able to improve quality of life and pain. And what was interesting, when I first started this trial, everybody said that older people, particularly in residential aged care, wouldn't engage in any sort of digital health solution. But 94% of those who were surveyed of our embedded qualitative analysis loved the program and recommended it to other people like themselves. Last year, I had an opportunity to look at adding some step trackers to the program. So we used just a feasibility trial. Would older people in community and residential aged care wear a Fitbit, the data attached from the Fitbit into the website, and what did they think of that? They actually really liked it. They found it easy to use. They loved the motivational aspects that come in with these embedded digital wearables. They needed some support, like they do with any technological program, as I do with a lot of technological programs. I need some support. But what it said is that it is an opportunity to look at adding wearables to this population in this setting to support physical activity and build better fall prevention programs. I just want to do a quick little case study of one of the clients from my original trial. He was admitted to a residential aged care. He has the mean comorbidities of my trial was about 6 different diagnoses. So Les has had a significant osteoarthritis, a history of a brain tumour, a history of frozen shoulder. He's had a knee replacement. He still has some joint pain, and he has had a fall history. And his social history is complicated as well. So Les represents what we're seeing in general in nursing homes in Australia. He gets a really good multidisciplinary assessment, looking from medical, from nursing and allied health on admission and regularly, and PRN if he does have any change in his medical condition or if he does have a subsequent fall. He's invited to attend some really good wellness exercise programs at the facility that he is at. The physiotherapists have trained all the lifestyle staff to do really, really good exercise, and they're actually introducing some sit-to-stand components where they have the staffing levels to add a component that they know that they need. The physios there do run some small groups based on the Sunbeam principles. So obviously not the big gym equipment that Jenny used, which was her equipment, but using hand weights, TheraBand, and ankle weights to increase the intensity of their strength and balance. Do they get opportunities for individual rehab by a physiotherapist? Do they get an opportunity to see an occupational therapist? Yes, but it is very, very limited. And unfortunately, across most facilities in Australia, you've seen a 60% reduction in physiotherapy and allied health hours. Are they using telehealth? Yes, at this site they are, because they had access to the top-up resources. But we also did a lot of work in some residential sites, and there are a lot of access issues in rural and remote Australia, and having telehealth and digital exercise and other solutions is going to be vital to support these facilities and deliver multidisciplinary interventions. What does the APA want? Which is pretty much, I think, what everybody in the audience wants. We want to see I'm going to be very physio-focused just at the end because, but I can, if there are occupational therapists out there and speech therapists and dietitians and exercise physiologists in the audience, you would have similar asks. But we want to see an increase in allied health in facilities. We want to be able to give residents living in nursing homes in Australia access to physiotherapy-led fall prevention programs based on Sunbeam. So we want to deliver programs, ongoingly if we can, but at least if we can adapt the support at home initiatives, which have 12 weeks restorative care principles, can't the residents in nursing homes get the similar program, especially if they need it? They need multidisciplinary fall risk assessments. If there's not funding available in aged care, what can Medicare do? Can we develop a Medicare item number around falls so that we can provide multidisciplinary visits, allied health under the chronic disease management plan? We think this is achievable. We think it's fundable. We can work with government to make sure these programs are sustainable so that we don't blow the budget, because we want to have fall prevention programs for all older adults who, if they're in the community and they have a fall, they're going to have access to really good restorative fall prevention programs. Currently in residential, they don't. And there needs to be equity of access regardless of where you live. And people who live in nursing homes have every right, from a human rights point of view, if we're looking at the new Aged Care Act, to receive these restorative care programs. We know that older people really value having an ability to be stronger, and we know that diet's important. They want to have the best medication to support them, but there's still a lot of issues around deprescribing that we haven't talked about in residential aged care. But being able to move with a degree of independence and a degree of quality of life is super important, and allied health has a big role to play in that. Just want to plug some digital health solutions that are coming. I know that Kim Delbert, who's led the development standing tall, is presenting later today, but I've had the opportunity to test the new version of her app, so it's going to be emerging. So keep a lookout for Standing Tall. That's it for me. I just wanted to give a little bit of a rundown. So I think I've almost caught the room up, but if we start looking at the beginning of the presentation, there seem to be a lot of barriers to delivering evidence-based restorative fall prevention programs in residential. There are so many benefits to having designated care minutes and RM minutes. We can see lots of quality indicators improving. The quality of lives of residents are improving. We're seeing some really good improvements in fall prevention. But while allied health is not specifically funded under the block funding, while there is not any allied health care minutes allocated or insisted upon in care minutes, it makes it really hard for aged care providers to have the funding to deliver these intensive programs. And we have to acknowledge that falls prevention is an intensive intervention and it requires support. So I think we all need to work together to keep highlighting that people who live in residential aged care have the right to multidisciplinary fall prevention programs as if they were living in the community. So that's it. I'll stop sharing and leave it back to Stephen.
Fantastic, Rick. Thank you very much. We do have a short period of time for questions. So I wonder, Pip, if you could come up too, just in case there's any questions, first of all, from the floor for either Pip or for Rick. While anyone's thinking right up, the question I've got is really the role of a champion. So you've both been champions, and I know it's all collaborative projects, but what happens if the champion moves on? And for example, you've come to Australia. Has it, collaborations in place, is it enough to maintain these, and what are the difficulties and the challenges in keeping these initiatives going? So maybe Pip first.
Yeah, thanks, Rick. Thanks for a great talk. It is difficult, but as I said right at the beginning, I wasn't the main person who developed the intervention. There is a strong team in the UK taking on my work. Younger, newbies coming into the area. I think we can all move on. And one of my, real passions was to try and move my aged care research from me being an occupational therapist to people who are actually working in the aged care facility. So the staff in the actual aged care facility doing PhDs, doing their own research in their own environment. So yeah, I'm happy for other people to take on the work and to move forward. That's my angle on it. I don't know if Rick's got any ideas.
Look, I think that you look at a lot of the allied health courses now, gerontology is a core component. It never used to be. When we look at the new aged care standards, it does call out specifically fall prevention. We know that fall prevention is in the quality indicators. So I think the concept that falls is now with us because we've got an ageing society. I think there is an awareness of it being a big issue and a big priority, and that if you've got a physio or an EP or an OT that's working in facility and they go, whoever is replaced, they will have the same passion that we all share in this room today. So I think that what we need to focus on from a implementation point of view is how do we support care staff to understand and give them the time and the knowledge so they can support these fall prevention programs as well, because these people need support throughout the whole day. We know it's quicker to put somebody in a wheelchair or a shower chair to move them from point A to B, but we know what's better for them is for the care staff to have the time and the skill and the confidence to walk them, to assist them to walk. So I think there just needs to be some time allocated, and time requires money, and then we will be able to embed these programs successfully.
Any questions at all from the floor? One down here from Lorraine Lovett.
Hi Rick, good to see you on the screen. And to ask you a question, I'm just curious, Rick, with the work that you're doing through APA, what work you're doing with the peak residential aged care organisation, ACPA, for example, because often I think, and I know that there's been a lot of work done by Jenny lobbying at the Commonwealth level. I know that there are other people lobbying around those care minutes and getting more allied health time built in. But sometimes through those peak organisations, when they meet at conferences, that's where you get your CEOs and your managers and the people who are the decision makers and sometimes board directors as well. And I think they're the ones equally that need to be influenced as well in this whole process of engaging, improving care with residents in Resi Care. So just your thoughts and ways forward in that, if you don't mind. Thanks, Rick.
So we have an organisation in Australia called the National Aged Care Alliance that has representations from all the peak health bodies, insurers, providers, and consumer bodies, and I've been involved in that for over 10 years, as is the Occupational Therapy Association, as is RACGP, ESSA, the SPA speech. So we do talk about this together. From an Australian physio specific point of view, we need to probably do a little bit more lobbying to the peak provider groups one-on-one. But when we have had conversations with them, they say to us, we want to see fundings designated for allied health so that we can provide the services that we want to be able to provide at a level that's required to deliver outcomes. So the conversations are there. It's just really hard to get the actual government to change the dial or to introduce things. It's to me, reform is too slow. And then the last 6 weeks, we look at the election. We have health has been very much a priority, but it's very much focused on primary care and supporting general practitioners to have sustainable businesses, which I'm very supportive of. But there needs to be a lot more work done on the concept that allied health needs support to have sustainable programs in primary care and aged care, and not just medicine and nursing. So we've got to expand the concept of allied health. We are essential to outcomes, just like medicine and nursing. So I've been having the same conversation, it feels like, for 15 years, and suspect it'll be it can't be another 15 years because we're seeing such an increased growth in the ageing population, and we're going to see the numbers of fall-related hospitalisations really burdening the hospital system. they're going to need support to keep people out. And really, that means giving older people better quality of lives.
Okay, great. Thank you very much, Rick. Thank you very much, Pip.